But we have a quorum present.
Yes.
We do. Okay. Now, we want to welcome Donna Sahlstrom, who's been attending our meetings, but is now a full-fledged voting member. So we get to vote tonight. Welcome aboard. Welcome back. Also, I'd like to welcome Mark Furman, Chair of the Partners Human Rights Committee. He'll be presenting a report tonight as well. And we also have with us Stacy Bryant, who's the Partners Communication Officer. We will be taking a picture of the board for the annual report. So after the meeting, everybody
no wonder they look nice.
We'll follow Ms. Bryant to where we're going to stage and go from there. With that, any agenda revisions? No agenda revisions. We move on to citizen recognition. Citizen recognition, we have two citizens who have signed up for public comment.
Did you sign on?
Ms. Short.
Okay. This is a bad angle, you guys. Hi, Mary Short, and this is my daughter, Katie. And we technically are in the Smoky Mountain Center, as you all know, but I live in Alexander County, and I like to document the meetings. I wanted to talk to you tonight about the IDD listening tour that Dave Richards is going around holding around the state. And I have been to 3 of those. Ugh, gross. Anyway, one of the things that has now come up as a theme is the discussion on care coordination and the absolute hatred of care coordination at the LME MCOs, and how it is not what targeted case management was, how care coordinators are not in any way, shape, or form on the side of the beneficiary or the family, that care coordinators are not in the least bit even navigators for us. And it appears that Dave may have finally heard it often enough that we're hopeful there might be some action taken. He gets the idea we all feel it's a conflict of interest, and he gets the idea that we really are out there and on our own. Remember, Dave used to be with the ARC of North Carolina, and they had targeted case management systems, and he fought long and hard when the LME MCOs were being created. He fought long and hard to keep targeted case management as a service that you all could contract rather than doing in-house. So, fingers crossed, we'll get back to that. Anyway, thank you very much.
Thank you, Short. Ms. Judy Taylor.
I'm a parent of an adult self-advocate whose hours are being cut. We requested a reasonable accommodation to email his approval or denial, and came time to get it, it was refused. Refused by several folks, refused again, until I finally found someone with some intelligence at Partners that got the idea that, oh, this is an ADA accommodation, and sent the email. The traditional lawful way for it to have come came several days later, which held up the reconsideration process. The reconsideration when you want to challenge. We did the reconsideration process, and we asked for it to be expedited. And in it, it said, indicate serious jeopardy to your life, health, and functional ability. My son included all, because he felt like it would, not to mention that he did have information for it. The denial came, and the denial said there was no documentation. You have to understand you're dealing with self-advocates, and if you want documentation, you should request documentation. You also shouldn't use words that self-advocates and family members don't know. Indicate? I polled 20 people, and all of them said what he did was what they would have done. We didn't tell him what he'd done. Timelines. On the 8th, it was denied informally by just saying that it's cut. Didn't say how it was cut. Finally, on the 9th, when we got the email, we found out what was cut. On the 10th, the QP had the peer-to-peer, and it was denied. Finally got documents formal. Notice I will come back to that later, but we did finally get those documents in the mail on the 12th. So that took from the 9th to the 12th to get there. The timeline delay deprives you of your rights to go to OAH because the reconsideration can take up to 45 days, which throws you in the next month. If you're not familiar with Innovations waiver, when you do your Innovations waiver, like his birthday's in September, you would do your paperwork in August, submit it by the 1st of September, and then by the 1st of October it takes place. So if you are going through all these different timelines, which reconsideration can take up to 45 days, you're thrown in to OAH too late to protect your services by having an injunction put in so that you will be able to keep your services. Reconsideration expedited would have only taken 5 days. That puts you in the next month, so after OAH process, and you're not able to protect your services, within the statute, and line 7 tells you about how you can protect your services. You have to do it during the month that your current plan is in. So throwing it over 15 days into the next month, and then going through the processes with OAH, you could actually be in a month that the judge could give it back to you, but you can't bill it because you can't get those services because you're not in the month that you can bill Medicaid. Documents should arrive from partners, not like this. This document doesn't have a logo on it, doesn't have a name on it. The only thing it says is Appeals Department with a number on it, which you would think was a credit card or junk mail. That's what self-advocates think. The time lapse should never overlap. You need to back up, even if you have to start doing things 90 days in advance to get it done right. The other thing that came, and I said I'd come back to it, was the original formal notice. It came in a package. It does say it's partners. It came first class, and it took longer than this did to come. And they're both treated as a piece of mail, just a regular piece of first class mail. Along with reconsideration review of 45 days, the OAH documents that you actually need to file with OAH is held hostage with partners. They won't give it to you to the reconsideration, which makes the overlapping going into the next month, deprives you of your right to get your injunction. You need to read it, not your lawyer, but you need to read it. You need to look at the statute and know what you're actually representing when you're sitting here on this board. In the denial, it states that he didn't meet percentages of goals to warrant the hours. This is habilitative services, not rehabilitative services. And for him to be successful, he needs his goals, he needs his hours, and he needs his services. But it did go on to say he's successful. So there's no way you can be successful and not do your goals. You know, face it, anything you do, if you're baking a cake or whatever, if you're going through the process and doing it right, then you'll be successful. If you're not, you won't. They cut 31 hours of service per month. Pardon?
No, that was Ken.
We are still in the reconsideration process, but I have filed an appeal with OAH, and they have accepted it. The partners keep saying that I have not. Well, I'd like to inform you that Dave Richards, Deputy Secretary, said yesterday at a conference that for issues like this, somebody needs to start getting common sense. He said that we couldn't keep dealing with the system the way it was. We needed to all have common sense. The hours could be approved, and they still need to work on the timelines. But self-advocate language needs to be improved too, because you're actually working with people with disabilities. And please add this to your list too. I called this morning to find out about this board meeting because it did not show up in the coffee break that y'all send out every Monday. And on the website, it tells you that the meeting is taking place today and at 6 p.m. When you click on that icon and you go to the actual piece, it says that the board meeting is at 6 o'clock and it's up here. But when you go through the pieces that say the date and time, the date's there, there's no time. You're working with self-advocates and you're working with families. So you go to the next icon and it tells you the location. You can't click on that icon to find out where the map is or how to get there or what room it's in or anything about it. And then the bottom one Says description, so there's no agenda or anything, and this is what your website looks like. You have serious problems with partners, and partners is supposed to be one of the best in the state. You need to get working on it because self-advocates and families aren't going to put up with this stuff anymore. You need to know more than just showing up to a board meeting, having a nice dinner, and saying yes. You need to ask questions and you need to say no. We need to fix these things. Thank you.
Ms. Barbara Richards.
Hi there. I actually wasn't planning on making a comment, but after hearing these folks, I felt that it was necessary that I do so. My son does receive innovation services, and I am his guardian. I'm a non-paid support. However, his father does provide the primary support for him. One thing I'm addressing, and I've been here once before, is the so-called fade out of services and how it's being thrown around as if it explains why there's reductions in services. And from what I understand, it's a major issue across the board. I've helped one other client that also had fade out. My son also experienced that, and fortunately I won back those hours through mediation. But I'd like to address that because fade out, it says no formal plan required. Let me explain that no formal plan required just means that they can cut your hours based on what they think the client needs and without justification. I specifically, when I was here before, said you need to have a formal plan and you need to give folks time and say, this is what we intend to do. We plan to reduce the services or cut this, or, you know, this is what we want you to consider. And you need to give them a period of time to provide, for instance, medical justification to continue that service before cutting it entirely and leaving people in a lurch for how to cover those hours and get the goals done. It throws families and the client as well as their providers into total chaos by cutting things without even giving them a chance to provide you what partners, the folks that are approving it want. I mean, they should at least be saying, you know, in order to continue this, we need this. So fade out of services is a big issue for me. I think that it is actually illegal. I think that there has to be some serious thought on how the approach of fade out of services are handled. My son particularly, it's not even an option. As he ages, he's going to need more and more services, not less. And that takes me to individuals, family members being providers. This is really interesting because the majority of people that are taking care of their family members, they had chosen professions, myself, my husband included, where they were making $40,000, $50,000, $60,000, $70,000 a year. But guess what? If you have a turnover of someone that's coming into your home, for instance, with my son, it would take 3 to 4 providers per day to manage his care. Or per week, if you can say per week. Let's go with weekend staff. If you can imagine that, I've looked into it. The average turnover in this industry, because of lack of benefits and vacation and the low pay, average turnover is 67%. If my son needs 3 to 4 providers instead of his father, that means I'm going to go through 2 or 3 a year. I can't even get him up to speed on his medical problems, much less anything else. Much less my son being able to bond with these people, because it takes a lot of time for someone with Asperger's to even engage with them. Okay? We don't choose to do this 365 days a year, 24/7. We don't do it. You know, these folks had a good paying job with benefits and vacation. I haven't had a vacation in 20 years. So I want you to really think about this. Are we going to disrupt these clients' lives, okay, by having this constant turnover and them never having stability and never being able to run goals effectively because you don't want to pay a family member to do it? Because I'm telling you, although my husband is up there in years and it's time to transition to another family member, my goal is I have three guardians, alternate guardians in place for my son. I have 4 alternate AFL, family AFLs in place for him to move on to. You won't be able to fade his services. I'm sorry. That ain't going to happen because he has some other medical issues. He is a 23-year-old with a 10-year-old mind and a 50-year-old body with polyps and tumors, and those are going to become more and more prevalent as he gets older. He will be in and out of hospitals constantly. So if you think that fading his services are going to happen, it ain't. And the only people that are going to show up day in, day out, 365 days a year, 24/7 without a vacation, for $7.75 an hour, is a family member that's vested in his emotional well-being. Thank you.
Thank you, please, everyone who signed up for public comment. Next on the agenda is consent agenda. So the only thing on the consent agenda is the board meeting minutes. Any changes to the board meeting minutes? Anything else? Motion? Second? All those in favor, signify by saying aye. Aye. Opposed? Move on to reports. Finance Committee report. Steve?
Well, no, I'm not going to give the report because I want to thank Mr. Bill Purchase. I was out of town, and he was kind enough to chair last week's finance committee report. So, Mr. Purchase, you get to do it again like you did so well.
They drug me out of mothballs. Well, we met via teleconference. We're going to meet in person next month. We met last Thursday, September 11th, via teleconference at 5:15 p.m. Staff Niels Eskelson and Susan Lackey were present. On the committee was Bill Purchase, Matt McCall, Pam Poteet, Barbara Anderson, Frank Zachary, and we welcome back Jim Klein, who had been fired in the previous month by Steve Epperson. Steve called me from Alaska at lunchtime to prove he was there. I heard the eagles swooping around Juneau. Anyway, we had a very good little meeting. It was more than normal. First item of business, we approved the August 14th minutes, which you will find in your packet on page 6 and 7. And as directed by the Finance Committee, I move approval of these minutes.
Motion needs no second. All those in favor signify by saying aye. Aye. Any opposed? Thank you.
Okay, on our financial statements, which you find on pages 8 through 10, if you have any questions concerning those, we've got Susan and Niels here. But I want to point out a few things. Of course, we're just starting the year, and those are July financials, and so they'll smooth out as things go along. But for a net, July we had a net surplus of $3,754,000. Our current ratio was 4.23 to 1, which is excellent. Our defensive ratio, we had 63.2 days of operating cash, which is going down somewhat from the previous month. The previous month was about 80 days, I believe. Our medical expense ratio was 84.3%. This is something, of course, we have discussed for some time. Our desired level is 95, and the state average level is 92.7%. So we're still working on that. In our claim processing, we're paying in 6.6 days from date received, which is certainly excellent. And actually, the number of days for the providers to get it to partners has been dropped down to about 15, so it's been paid in about 21 days. We also approved a budget revision, number 1, for fiscal year 15. I think you'll have that on page 10 in your package. There are 3 items in here. First, there's a reduction in fiscal year 15 allocation from Burke County of $21,455. A reduction in fiscal year 15 allocation from Cleveland County of $150,739. And then some 3-way hospital contract addendums received from DHHS, which is late in fiscal year 14, which are we're adding on to the fiscal year 15 budget. And I believe this has to do with Davis and Kings Mountain Hospital. And that's $341,625. For those, if you don't know, 3-way contracts are a contract between the local hospitals, DHHS, and the MCO, LME, to purchase expanded inpatient psychiatric capacity. The total increase in our budget will be $169,431, which will make our revised budget $316,132,260. And as directed by the Finance Committee, I move approval of this budget amendment, budget revision. Excuse me.
Motion needs no second. Any discussion? All those in favor signify by saying aye. Aye. Opposed?
That's all I have, Mr. Chairman.
Thank you. We'll move on to CFAC report. Ms. Mitchell.
The CFAC met at our regular meeting on September 8th, and our training came from Kevin Oliver, who is CEO of Phoenix Counseling, and it was on substance abuse and mobile crisis. We had several CFAC members who were able to attend the Dave Richard listening session on IDD, which was in this room on September 4th. This was hosted by Partners for the Families of IDD and IDD population of this area. And the CFAC members helped with welcoming and refreshments and those kinds of things. We continue to work on our efforts to fill our CFAC vacancies. We have 2 wonderful potential members who are just waiting for the recommendation from the admin committee for Cleveland County, and that will give us 4 vacancies, 2 from Surrey on IDD and mental health, 1 from Burke, which is substance abuse, and 1 from Lincoln, which is substance abuse. And we continue to ask your help if you're from those areas for those, but we're getting there.
CEO report.
Thank you, Mr. Chair. Just a number of things to present to you or update you on tonight, and I've grouped these into 4 different areas to try to keep up with. And the first is to talk a little bit about the oversight of partners' activities. I want to talk a little bit about the state update, the Western Regional Partnership update, and then tell you some operational issues going on within partners. On the oversight of partners, we've had, since our last meeting, we had our external review. It's from an independently contracted organization that the state contracts with. They go out and do a review of MCO operations. They came to our place for 2.5 days. A very good visit, had some very good things to say about us, and we learned some things that we need to do better at with this group. We talked last week when we were in Raleigh together with the Department of Health and Human Services. We go through a number of reviews, and this one is the first time that we've been through this external quality review, EQR review. And what we found and we learned through this through that process that we need to improve on is they look extensively at our policies and our procedures and our plans and make sure that everything ties together in terms of how you're going to say that you're going to do things. And as we shared with them, the growth that we went through and the rapid changes that we've had to go through over the last couple of years, oftentimes we changed things to make them better, but did not always go back and tie the policies and the plans together with those changes that we had to implement so quickly. So we have some work to do now to go back through and make sure that all that catches up and everything in a plan and in a policy actually ties and directly reflects what we're doing. So a group of staff are focused on making sure that those things get caught up, and that we have plans in place or procedures in place to keep those current going forward when there are those things that get out of sync and we continually have to make changes. So, but overall, they were very pleased. They had some very complimentary things to say about how we've been executing as an MCO, and they'll be back in a year to go through that process again. So that's one of our external reviews that we go through. We have another external review that's coming up at the end of this month. We're going to go to Raleigh, and the team of individuals within the Department of Health and Human Services have us there for a couple of hours on a day to go through operationally what we're doing, how we're addressing some of the state initiatives, challenges that we have as an MCO, how we're responding to their direction. So there's another opportunity for us in the coming weeks to have oversight from the state agency, look at what Congress does as an organization. We've already gotten our date. You've heard us talk a lot every year about Mercer, the external review that the state contracts with, to have them come in and look at what we do. That date is being set, likely to be the first week of February. And that's an extremely comprehensive review of everything that we do as an MCO. They basically take the contract that we have with the state and go through and make sure that we're in compliance with the state contract. One of the things that they look at, we shared with you that last year after they came, their report and the things that they noted that we needed to address, and we have an action plan that we've been working on to address those things. And they'll look at that when they come back and see, did we address or did we remedy all the things from last year? And they'll go through that process again to see what we've done or how we're performing. So that's the third review of partners operations is coming up in the next couple of months. And then after that, that should be enough, but it's not. We got another one that's coming up after that where we'll be reviewed by our national accreditation company, URAC, who is planning to come sometime probably late March. And again, theirs is a comprehensive review of selected operations that we're accredited to perform. There's a whole lot of information that we send to them. They do a desk review, then they come on site and do an on-site review of those activities. So there's a lot of oversight that is either in process now or that will happen over the next 4 months from really 4 different opportunities that people look over what we do as an MCO. And again, so far, all those we've been very successful at. So I think that gives us all reassurance that we're continuing to move and build in the right direction. We certainly aren't there in terms of INSO. We're continuing to grow and learn, but it's helpful. And we treat those. We tell the external review companies when they come, we consider ourselves to be a learning organization. That the EQR visit was extremely helpful for us. And we wish that we actually would have had that about a year ago, because that would have pointed out some things that during this rapid change we would have probably been more in tune with. So again, just wanted to let you know kind of where we are from the external review sites. A little bit on the state update. I don't remember at the last board meeting if we knew whether or not there was going to be a special session. I knew that there was talk about whether or not there was going to be a special session in November to address the Medicaid reform. The Senate wanted that to happen. They had made put some things in their closing session that they wanted to have a special session. The House did not. So the House did not. They ended their session without agreeing to that special session. So there's not one that's scheduled. I think as we talked last month, that typically the only way a special session can happen is if it's called by the governor. But we thought that maybe they were going to put it in legislation, which would have circumvented that process or made it not be required to be declared by the governor. So they didn't do that. The only way it's going to happen now is if the governor doesn't put it in the special session. And so far, when you've heard him make public comments, that he doesn't necessarily intend to do that. Not that he's completely opposed to it, but it doesn't sound like that's high on his priority list to call a special session in November. So if that doesn't happen, if there's not a special session that happens in November, Medicaid reform will be picked up during the long session when the House and Senate reconvene after the first of the year. As you know, there's 3 different plans. The House has their version, the Senate has their version, and the governor's plan is different. So there's 3 versions that would then get reviewed and discussed when the Senate and the House come back together after the election with whatever new members are elected during the fall election. One of the things at the state level that's going on is Niels and Susan and I had our first visit down to Raleigh for this year's rate setting process. It's interesting because typically, as you know, our Medicaid year has been on a different year from our IPRS or our state or our fiscal year. Medicaid operates on a calendar year, and our IPRS funding operates on our fiscal year, which is July 1st to June 30th. They're going to link those two things together now. They're going to change the Medicaid year to coincide with our IPRS year, which is good. We've been advocating for that to happen, for those two things to get on the same cycle. What that means in terms of rate setting for Medicaid is that they now have to not go for a full year contract with us. They're going to split into a 6-month contract from January until June, and then they'll issue a 1-year rate for us to coincide with the new Medicaid fiscal year. So what we're debating now, or what we're going through and doing the process with now is setting that rate, which will be in place from January the 1st to June 30th. So as you remember from last year or prior years, it's a 2-part process. You go to Raleigh the first time and they review with you how they're organizing their data, what data they're pulling, kind of making sure that they capture everything in terms of our claims history. They'll take all that, they'll make an offer, and then we'll have the opportunity to review it, accept it, or challenge it. One of the things that we've talked about with them is a lot of the initiatives that we have aren't necessarily built into our historical claims. And you heard Mr. Burgess talk about, there's our spending rate and our medical loss ratio, and that there are things that we want to do to continue to grow and expand the service continuum. But the problem is if they don't forecast that into the rate and we start those things now, then we'll overspend this year, which the state legislature looked at last year very, very closely about not overspending what our capitation is. So where we are right now is we had the first visit. We're showing them those things that we have planned to implement and translating that to what we anticipate the cost of those things to be. So when they set the rate, it will be the historical cost for the historical claims plus the new initiatives that we have planned, which hopefully will get us to a fair rate, and we'll be back. Niels, and Susan, I don't know when the next meeting is going to be, if it's likely to be before we meet again. If we have an exact date yet, if we'll be able to report it.
wanting to meet sometime in October,
So it may be before the board meeting. If not, then we'll just give you an update next time about what that date is. Then down to the more regional level, the Western Regional Partnership, nothing new to report in terms of the steering group. We did not meet. The steering group did not meet in September. And again, not because nothing is going on. The work groups continue to meet. The work groups have continued to be very strong and working together. And I had the chance to talk to a couple of our staff this week about how their work is going. There's a lot of cooperation and good work coming from those independent work groups. From the utilization management standpoint, or the provider network standpoint, of those trying to make life easier for consumers and providers across our western region so that we're not doing things 3 different ways. So we're trying to have a uniform approach even prior to merger. 2 things that are happening, just so that you know some of the deliverables that have happened. We have now started to have the call center have the capacity to pick up calls for each other. So that minimizes, if not completely eliminates, the time that a consumer is not able to get a live person on the phone. There's no voicemail, it takes people out of the queue a lot quicker, so they're not on hold as long. That process, we've now been rolling over calls with each other if there's a need for overflow calls to be answered. So that's been a positive outcome of these work groups. The other thing is we're finalizing now the relationship agreements between our 3 organizations to do credentialing together, so that we credential providers once. And then you've heard us talk about that before, that a provider right now has to apply for 3 different organizations. We're trying to streamline that and cut down some of the administrative costs for our providers, and they'll do that one time with the Western Regional Partnership, and that's scheduled to go live on November the 1st. And the agreements and the testing and that kind of stuff is very much in process right now. So those are the things that are going on at the Western Regional Partnership level. And then just a couple of points about things that are going on locally within the partners area. There's a document that I want to make sure that we get to you tonight. It highlights our first year successes. It's already out at people's place. So that's a document that was put together just to identify some of the things that are significant accomplishments for the organization during the first year of operation. It goes through a number of different highlights, and so if you take a look at that and have any questions, certainly let us know, and we'll try to continue to publicize that or push that out so that audiences throughout our 8 counties get that. One of the things that we talked about, and you've heard a lot of talk about with and that's the service called PRTF, Psychiatric Residential Treatment Facility Services. We have gone through a lot of work with those providers over the last 18 months and really have identified what we want from those providers in terms of a quality service. Oftentimes over the course of the last years, decade, that service is something has often been misused by the providers. It's been used more for the provider's benefit rather than the consumer's benefit. And they weren't as aggressive at trying to move those consumers when they're ready back to their home communities. So we have sent out an RFP to the providers that want to do that service in our catchment area, setting a bar about what we expect those service providers to do. Those have been received, the deadline has happened, those are in now, and our clinical team as well as other people within partners are reviewing those, and we'll go through a selection process to identify which contract providers we want to continue our relationship with for that level of care. One of the things that I mentioned last time, and you'll continue to hear a lot about this, is one of the areas that's in the Secretary's plan, that's in the House plan, that's in the Senate plan, that we need to continue to focus on is integration with primary care. We've had meetings over the last month with our community care North Carolina partners, and we're on the verge of hosting a kind of a big brainstorming session with them to try to take that idea of integration to a level that we haven't been at yet with the local level. It's something unique, I think, for the state. So you'll continue to hear that. We'll probably have had a meeting by the time we meet again in October and can give you an update on that. But integration is the one area of the Secretary's plan that we probably need the most attention to. A lot of the other deliverables that are in her plan, we meet, and we've been meeting. A lot of the cost predictability and increasing the access to services we've done. But integration is an area that needs a lot of attention, across the state, and certain partners intend to be a leader with that. Last thing I'll mention is just for those that weren't able to attend, Commissioner Phillips was able to attend. We had the kind of informal launch of a new 12-bed transitional living facility in Surrey County. If you're not familiar with that, we took an old hotel that had been not operational for quite some time, converted it into 12 single-bed units for transitional housing of consumers when they're stepping down, perhaps out of a state institution, and they need some stable living environment before they can transition into the community. It really is. We had a lot of people that came through. A lot of people were very impressed with what's going there. It was a partnership between partners, the housing consortium in Surrey County, the provider that also came to the table with that. So it's going to fill a void. There is not enough housing opportunities in any of our counties. But this was a unique opportunity to create 12 new units for that northern territory in Surrey County. And that's kind of exciting to see. Mr. Phillips was there, as well as another one of his fellow commissioners, and a lot of support from the county commissioners for that service up there.
We'll move on to the discussion agenda and crisis services update.
Chairman Farley, good to see you. Good evening, everyone. Hope you all are well today. I'm going to speak to you about crisis services, and there was an additional handout that was provided to you at your place tonight. It is a replacement to one that was sent to you by electronic means because we had one date that was incorrect on page 2, and we corrected that and just have a fresh copy for you. So, and just want to make sure that, number one, that you understand and know all about the crisis services that are provided in the Partners Behavioral Health Management area. And number two, about some significant changes that will occur and have an impact on crisis services delivered in our 8-county region. I provided to you on page 1 just a bulleted list of all of the crisis services in a continuum that I hope that you'll kind of see in the bar up at the top where you see the kind of lighter blue going to darker blue. That's a gradient. We're trying to show you that there is a continuum here. And I'd like you to see crisis services actually being a part of prevention, crisis services being a part of early intervention, acute intervention, crisis intervention, and reintegration. In other words, crisis services have a place throughout the whole continuum. You just think about it just a minute. If we provide a service when someone needs it at the right time, they may perceive it to be a crisis. We may perceive it to be we provided a service that prevented a higher level of service later on. So that's how it works in a preventative way. And then, you know, if it doesn't happen on the front end, then on the back end, when things get really tough, then also it might be something like a crisis intervention and treatment, or even a reintegration process where somebody's coming out of the hospital, and then they might perceive that there's a crisis, but what we might do and provide to them is actually helping them to reintegrate and prevent future crises. So when you think about it, you know, crisis services actually have a place across the whole continuum. But you've heard about most of these services. You might have seen those in operation. You might have heard us talk about them. Everything from, I still actually remember the night that Diane Morrison, our Director of Customer Services, came to speak to us. And it's been at least 8 or 9 months ago. And she told you all about the 24/7 call center that we manage that's based up at our Elkin office. Now, I remember a number of you were impressed with the technology, both on the phone side and the computer side, that helps to make that work, plus the number of people that we have that are there. That's what we mean by that toll-free crisis access line. Walk-in urgent care at outpatient centers means that you can walk in when you need it, and we've got those in all of our areas now. Same-day access means that you have same-day access to not only just crisis or urgent care, which is bullet number 2, but when you need something, you get it. Again, maybe a little on the lighter blue side of the bar, but you get it at the right time, so that you can do something first. Mobile crisis is more often seen when the acuity is pretty high, and then within a community or in some kind of residential setting where a mobile crisis team may go to, and we may send them to in order to mitigate the crisis at that time. And on down the line, I want to point out facility-based crisis services. We've talked about those here quite a bit. And these are actually hospital diversion residential beds within our communities. We have 44 beds of that. And on any given time, 85% of those beds are filled on pretty much on any day. So with that in mind, you think about what could have been happening if those beds were not available. Again, people would probably be in a hospital bed. And the hospital bed carries a much higher cost. Plus, it's a higher intervention, it's a higher level of care. So we really like those 23-hour observation beds and the crisis stabilization residential beds as diversion options for hospitalization. And just as a side note to that, the North Carolina General Assembly has enacted some legislation this summer that directs a study and a new service definition for children and adolescents to be served in a crisis center like that. Now, we used to have that, and for those who've been around with me a long time, we know that we provided that actually in Statesville at the crisis center there. And our 3 locations are Statesville, Gastonia, and Shelby. But we had 2 adolescent beds in that unit, but the state took those away in 2006 or 7 because they didn't like the way the service was designed here in North Carolina, but there's been a resurgence and a new interest in that, a renewed interest in that. So we have detoxification services, crisis intervention trained officers in each of our counties who are really operating now as first responders for people that have a mental health crisis. And then we have crisis beds for children in group homes, and tonight, I checked, we have 4 beds filled right now. In the 8-county area. We have 2 beds filled down in the southern part of the area, in the Gaston County area, and we have 2 beds filled in the Surrey County area. So it's all of those things that help us to manage the crisis services carefully and all. And so we really want you to be aware of that. There is a kind of a central goal, and I always want you to know as much about crisis services as possible, because crisis services oftentimes are the things that get noticed the most. They're the ones that, when something doesn't go well, everybody seems to notice it. So a true crisis brings a lot of that attention. Our central goal for these behavioral health crisis services, as you see there, is to intervene in as low of an intensity as possible in order to mitigate that crisis. So whatever the lowest level, we'd like to do that. You go back to that blue bar on the top, on the front, and we'd like to intervene over on the left-hand side if we can. Sometimes we don't get that chance, and we're going to do it over on the right, but if we can, we will start on the left. I want to bring to your attention a couple of big changes that are happening here in North Carolina also that affect crisis services. And I say these because depending on which side of the fence you're on, some people may say this is terrible, and some people may say this is good. And you might hear about either one of those, although sometimes we might only hear about some of the bad things. So think about this one. So on October the 1st, so coming up, we're going to have a new and improved comprehensive crisis prevention and intervention plan. And so every consumer that is in enhanced services, and there's a couple of exceptions where that even people that aren't in enhanced services will be required now to have a new comprehensive crisis plan. And that's going to be affiliated with their regular plan. It will be an add-on to that. Now, we've been doing this for a while, but these regulations are now just coming into play that require certain people to have these types of crisis plans. Of course, it's highly recommended also for other people, not just people that have enhanced services or those that have another person-centered plan, but for anybody who is at significant risk of experiencing crisis events. This can help mitigate crisis. It's a plan that helps people to self-initiate how the crisis should be managed from me personally, and it has their family participation and the consumer participation, and allows a provider to help them to do that. And this would be renewed about every year or whenever their plan comes up for renewal, so it's going to be at least an annual event also. Well, so there's a little bit of downside. This takes time. It takes effort, and essentially it's the unpaid effort that providers have to deliver. So you know kind of that side of it, and then you know the good side. I mean, I think all of us can recognize the real value of that, but also it also means that providers are being given a little bit of complaints about, well, we really didn't want to do that for all those people, but that's one of those changes. Second big change begins on January 1st, 2015. And this is where that a new rule or policy is being put in place that will prohibit us from paying funds for mobile crisis services that are delivered in a hospital setting. And the hospital setting is defined, as Paul and I learned 2 Fridays ago, as an emergency department or an inpatient bed. It doesn't matter. They see inside of the hospital, when you get inside the door of the hospital, that's where they say we cannot pay for mobile crisis services. The fundamental theory behind that is that it's essentially a double payment system, so that we are going to pay for a Medicaid recipient to receive emergency department care, and then if mobile crisis went there, and we paid mobile crisis to be delivering a mobile crisis service in the emergency room, then that was a 2-payment system for that. So they're pulling that back out as of the end of the calendar year and forbidding us to pay for those services beyond that point in time. Again, I think you can see both the good and the negative side of that. Hospitals that, we have several, that become really dependent upon a mobile crisis team to come in and provide a consultation service, assistance to the emergency department, all of those things, that's not going to be able to be done in this way. Now, it does permit hospitals to contract directly with mobile crisis providers and pay their own money to do so. It just prohibits us from spending the Medicaid money on that process. So again, some significant changes, and we wanted to be aware of those. So let me just pause a minute and see if you want to entertain any questions.
Yeah, that last part. What's going to happen? Is that going to be a reduction in services for consumers in the crisis?
Well,
Up the double payment issue?
yeah, well,
All of a sudden I see $1 go out of the system, and so I see services not being delivered.
well, the person is still going to get emergency department services. That's not going to stop. So what you experience in the emergency room we can imagine that tonight. That will still happen. It's this extra mobile crisis service. And remember, though, it doesn't prohibit two things the hospitals still have in their pocket. Number one, they could use their money to contract with a mobile crisis provider who would deliver mobile crisis services. Not really ideal, but that is going to be permissible under this. The other thing they could do is they could contract with professionals, licensed professionals like a psychiatrist. Just like they do with cardiologists, any specialist in a healthcare setting. If you go to the emergency room and the emergency room doctor believes that you need cardiology care, they're probably going to call in a consultation with a specialist like a cardiologist, and that's how that'll work. Or a pulmonologist, any other specialist. They can still do that, and we would still pay Medicaid funds to somebody who's credentialed and enrolled with us for that consultation. But that's different than mobile crisis. The purpose of mobile crisis is to mitigate the crisis and move the person from one stage of care to another. The purpose of a consultation is to offer a plan, an intervention for that person at that point in time to bring them to a different level of symptom relief. So they're recognizing two different persons.
What's the mobile crisis unit usually composed of? Who's on that team or who's dispatched?
Excellent question, Matt. It is a team of people that includes...
What's the normal size? 2 or 3 people?
Well, the team that's defined by the state of North Carolina actually has 5 people on it, but they're usually individuals that are responding. So it's a single person with a backup team of all kinds of professionals.
What's the usual on-site? What's the average time being dispatched to being on-site? How long is that?
We track that every month, and I just saw it just today because we were just looking at it. I think 1 hour was 1 hour to 1 hour and 6 minutes, something like that.
The longest one was 1 hour and 49 minutes. The regulation requires within 2 hours. The longest average that one of the companies had was 1 hour and 39 minutes, and that was for extreme cases. That was actually their longest urgent. Emergent was...
You have to travel a long ways in Iredell
So
County.
usually these are going to be for consumers that are having a manic episode, that kind of...
That actually could be if they were in crisis in a manic
Are
episode.
local law enforcement agencies calling us to dispatch mobile crisis, or
Yes.
are they going straight to the ER?
But both of those happen. Good question.
I think one of the things that Matt was talking about, we have for a long time been trying to help the community understand that there's a better place to get people care than going through the emergency department. That's not good for the system in terms of the cost of the system. It takes away about, and it is by far not the best avenue for a consumer to get the timely care. I mean, they get stuck there and they're sitting there without the true intervention. It's safe in the sense that we've eliminated necessarily the threat, but it's not getting them to care. So this may very well force that issue for, and consumers get mixed messages. As we've often talked in here, you drive down the highway and there's billboards flashing saying, ER, only wait 5 minutes. So people are here, maybe that's where I need to go to get help, but when you get there, you're stuck for hours, if not days, if you're a psychiatric patient. So it may actually force law enforcement or other people to try to help us. Let's intervene with them somewhere out in the community and not get stuck in the emergency room.
Will we be able to see for Medicaid or consumers that are receiving ER care? Will we know about that? If ER is providing care? We will know.
So again, like what we know.
So say someone is in ER and they are receiving care, we will know if we do it from that.
If it's a Medicaid patient, we will get told that. That's correct.
And we will then hopefully proactively reach out to that person after they're out.
Exactly.
Now, is that only if you contract with the hospital?
No. Well, we have arrangements with every one of the hospitals, and for emergency department care, we are compelled to pay for those hospitals.
But after July,
We'll still pay for the emergency.
Right. This is for mobile crisis. Mobile crisis delivered in a hospital setting. That's where the rule stops. Again, as Brett said, and we've even had other strategies to move mobile crisis out into the community. We will, if you actually go back to that blue bar again, what we want to do is to have mobile crisis intervene higher up on the string. And and rather than at the hospital, which is at the end of the road. And so we really wanted to do that. We even have paid an incentive, a bonus to the mobile crisis teams to provide the care earlier on in the community when they can do it. So what Matt was asking a while ago, when law enforcement calls the mobile crisis team from the community, the mobile crisis team can meet law enforcement at a home, at a trailer park, at a residential center, somewhere beside a hospital, and intervene at that time. And so this is just another way to help push it back upstream.
Sorry, but I thought Matt was asking, after the fact, after January, if someone goes to the ER and has a, breakdown and needs medical treatment, the hospital's not gonna call medical crisis. It's kind of like, if you go to the ER now, it's straight home, they send you out the door, refer you to an orthopedic care next day or sometime that week. You can't do that in this situation. So, if the hospital doesn't contract, what's going to happen?
And, well, what you just described may happen if they don't contract with some professional, or else they're going to have to start and initiate treatment at the emergency department. I'd say that the majority of our hospitals have some type of arrangement like this. And a lot of them do it with telepsychiatry. So they have a mobile cart that has a video camera and all, and they bring that into the patient room. And a doctor is somewhere else, in Winston-Salem or in Concord or somewhere else, and they are piped in, and they see the patient and offer a consultation to the emergency room for that particular purpose. A lot of our hospitals are doing that now, but several still are not doing it. And those are the ones that have become more dependent on mobile crisis. This may force that a little bit further too, to get the hospitals to contract to provide telepsychiatry.
So,
Yes, they can.
so come January, and this is why I thought Matt was asking, and I do apologize, we will not know. We have no way of knowing come January 1st if the hospital is treating.
David's, we all check every day.
Yeah, we actually check every day. We know them, so we know if they're treating it. This is emergency room treatment and mobile crisis intervention. Those are just two different things.
Okay, but if the hospital doesn't contract with the provider,
Yes.
you will not have no way of knowing.
We'll still know.
Yes.
You still will not.
Right.
2 ways.
Yeah. And let me say one more thing, and then we'll get information to it. So we have 2 ways of knowing. I'll give you that. So we have a daily conversation with every hospital emergency room. So we get the number of patients, we get the name, we get all the data and information about what they're in there for and how long they've been waiting. So we track that every single day. It's tracked at 10 o'clock in the morning. So it's a slice in time. Then if they're in the hospital and they're medicated, we again are going to be paying a claim for the hospital services. So there's another piece of data that we have that we would know who's there and how much the cost was and what they received. Then you have what Paul mentioned, we actually have the care coordination, so we have hospital liaisons that are in the hospital setting and move through the emergency rooms. They pick up with knowledge and surveillance the people that are there, and we then link them to the providers on the next day. We help them to get to those next places. That's why that the same-day access and the urgent walk-in, we can get them right out of a hospital and into a place for the same day. And so it's a step down. It's just immediate. And that's one of our core functions, is doing that coordination.
And one thing just to kind of tie this to the conversation we had earlier about immigration, a fourth way that we have access to now that we need to enhance is that relationship with the community cares of North Carolina. Because when a Medicaid consumer goes to the emergency department, they know that. They have their own internal system where the emergency department notifies them that there's an admission to the ED that's a Medicaid recipient. So with our partnership with CCNC, when that's a psychiatric patient, then that linkage needs to happen so that we also know that that consumer has hit the emergency department. Because you're right back, pay claims comes 60 days later, so we can like real-time evidence that they're there.
My concern is a monitor. I mean, how is that going? I mean, and this is, I've seen this, you know, and I've gotten emails in regards to this, and it's really scary, you know, and I understand what you're saying, you see all that, you know, through the CCU network, but for a non-Medicaid client, how are you guys gonna know that?
Every day, we take that snapshot of contacting every ED in the area. 13 different emergency departments we have on the spreadsheet, and I get a copy of it. Our medical director gets a copy of it, several other people get a copy of it, we look at it. And we have even color-coded the wait times for green, yellow, and red. And just like the stoplight, green, we don't worry about too much, that's usually within hours that we're finding that out, you know, that they're there. The yellow is within 24 hours, and red is anything over 24 hours. They're putting an indicator there for me to notice and to say, we've got somebody that's been in the hospital emergency department waiting for a placement greater than 24 hours. So that's when we start saying, what's the deal? Why is it? What's the
How many were in red today?
Sorry?
How many were in red today?
Oh, gosh, let's see, I think, only a small number, maybe 4, smaller than,
Those are persons who've waited for more than 2 days in the ER?
more than 24 hours.
More than a day.
So the ultimate fix is to prevent them from going there. Because you're right, once they're there, the hospital somewhat is stuck because of their guidelines, and we are somewhat stuck because we don't have the ability to do as much as we would if we could see them out in the community, or see them at one of our crisis detox centers, or see them at some other place in the community. So that the ultimate place we've got to get to is trying to prevent them from ever going there.
Does this new rule impair our ability to do something once they've been there 24 hours?
No,
In other words,
doesn't.
Just one comment about law enforcement. The CIT has been instrumental in keeping emergency room to visits down, especially in Cleveland County. They're meeting and they're CIT trained officers that are dealing with these consumers. They're going to someplace else. We've started several classes in Gaston now. We've got one officer who is never going to try to use the ED again if she can possibly do it. Because she says, I didn't know any of this stuff was going on until I took this class. So crisis intervention has really helped in a lot of the counties with this.
Yeah, one question I have, David, is if I'm a provider and I notice this patient needs more than I can give him, and I got to take him to the emergency room, does my responsibility end when he walks in the emergency room? And walk through that if he stays 2 hours, who picks him up or delivers him there, or 4 days or a month? And I can see why the government wouldn't want to do it. But how does that provider has to be on his toes to know whether or not to walk off that scene.
Well, and we would actually hope that that provider would do all that they could to keep them out of the emergency room, and and so really established providers that have a lot of resources and have a depth of experience may be able to do something to kind of keep them out again, to keep them in the lighter blue area. But let's just take that scenario and let's say they still can't do it. So, and because people need to be hospitalized every day in the partners area, and that's very legitimate, and that is going to happen. So they don't have to always go to the emergency room. So you as a provider could contact the hospital and get them into a hospital bed without going to the emergency room. Or you could use the emergency room if that's the hospital's practice. A lot of times hospitals want that to happen because they can do all the screening whenever someone comes in the door there versus anywhere else within their confine. So your responsibility, depending on who you are when you take someone there, if you're a provider, if you're a family member, different levels of responsibility. But essentially, when you cross over that line into the hospital, you're asking the hospital to help they become responsible to properly assess and make the determination of what the person needs at that time.
You know, one of the things, as a managed care organization, we have better leverage than the system had prior to being managed. I mean, it used to be with a provider that chose that route, that had a difficult case and didn't want to deal with it anymore, they could take them to the emergency room and walk away. and there wasn't a whole lot of consequence to that. Now we can, and they were doing that for the provider's benefit, not for the consumer's well-being. Now we can select who we want to be in the network, and if that's their pattern of behavior, that's not who we're going to continue to contract with. So we have a lot more leverage now as an MCO to stop what that practice, again, it's for their benefit rather than consumer, that we didn't have prior to being a closed network.
And we would also alert our care coordinators again about that because they're looking at what you are providing that person and asking the question, is it the best service at the best time in the person's life? Is it the right intensity and all that? So one more comment I'd like to make is something that Ms. French and I talked about a lot with Divisional Health. We have let them know that another loss to this is one of those intangible losses, is that it could be that mobile crisis does keep people out of going upstairs to an inpatient bed. So to the extent that they have been doing that, then we lose this opportunity when mobile crisis is not in the emergency room. And so there was a little bit of a second look at it versus, if you're paying for a consultation, if you're a hospital buying a consultation, it's just like any other medical service, and you're going to trust that consultant to make the right recommendation. And so that may happen, and we're going to look at that data. Beginning January 1, we want to look at it and track it back to this year's and see if there's any higher levels of admissions because of this happening.
Well, and on the other side of that coin, I know an individual whose wife had a baby. The doctor was in Montana on a big deer hunt, and he charges him $500 for delivered hay. And I know where the government is in trying, and that's one of the big reasons for doing all this incorporation to get rid of part of the fraud and all that kind of thing. But also, the thing that I was thinking about in that emergency room deal is, if they're not there, they shouldn't be asking for pay. But if let's say that I am engaged with that individual and I feel like it's important for me to be there for the next hour or two, do I get paid? Or does that come as a gift from me as a provider?
As a provider, there is a rule that when you're in the hospital, that in most cases you can't unbundle separate services and do that. Subject to a couple of exceptions, like a consultation in the emergency department or an individual physician charge in a hospital room. But normally the hospital charges are bundled all
Okay. When I broke my leg and went to the ED, and they had an orthopedic surgeon who looked at me, made a determination, got me into surgery to reset my leg. Right now, somebody goes into an ED and they don't have any social services on hand. They call that a crisis. We're paying for the ED room, and we're also paying for the mobile crisis versus to deliver services there. So I think this is what the state is looking at, is if the EDs will hire an orthopedic surgeon to be on hand to take care of people who have broken bodies, why aren't they also paying for the social services people who come in and have behavioral health issues? So that's kind of the other side of the coin.
Yes, what's their motivation to do that? Hospitals, what's their motivation?
They don't have to pay for it. They're not paying for a mobile crisis to come in right now.
Or are you asking what would be their motivation to pay if they have once?
Money out of the system, basically. We're saying, well, hospitals are going to pick up the difference. What's their motivation to pick up the difference? Are they going to do it?
They still bill
Yeah,
for it.
just the same, if you go as a mental health person, okay, and there's a mental health person on there to help do an evaluation on staff, what happens?
See, and that's what I'm saying. Are they going to refer,
I mean, what happens?
how are you guys, and that's what my whole point was, if they don't write down that diagnosis, or if they don't put in their medical records that this person, needs psychiatric care, how are you guys gonna know that if that's not there? And they don't tell you that information.
Somebody on staff to take care of
Exactly.
it.
What am I gonna do? Refer you to the walk-in clinic in the morning? How are you guys gonna know they're there? You've got, some person that needs help walking on the streets, the hospital released them to call, you're right, Steve. They're not gonna contract with mental health because you've just taken one part of that double money out of their pocket. So that was my whole thing. How are you guys gonna know, especially on the non-Medicaid client?
They weren't getting the Medicaid money to pay for
There was, right.
Right, we were actually paying the mobile crisis provider and then paying the hospital.
But it's like Steve said, it's what I was trying to, that was my whole point earlier, is that if the hospital doesn't actually put down that this person needs psychiatric care, or that's why they actually come into the ER, how's the hospital gonna know? I mean, they're gonna have to refer someone that has a broken bone to an orthopedic if there's not an orthopedic doctor there to do that.
Isn't one piece of that person staying there in the hospital that they need psychiatric care, and the doctor has to sign a document that says they need psychiatric care?
That's my whole, how are they gonna know? How are you guys gonna know?
And the reason they're staying there is because you're waiting for a bed. And in order to get a bed, two doctors have to sign that document, and the other doctor to sign it is the doctor in the hospital that they go to.
And I think your question is about the integrity of what a hospital might do.
Exactly.
And so let me ask you in a cynical way, could we detect if a hospital did not properly diagnose a person's mental health condition, and that would be more difficult for us. If they called the patient a diabetic rather than a psychiatric patient, we would not get the click in the morning, we would not know that they were there for psychiatric.
Now, and which, listening to the comments, have any of you actually contacted with the local hospitals now since you have that daily contact with them already and have talked to them about this change and have pretty much asked them, what are they going to do? I mean, do they have any suggestions, or are they willing to?
Well, again, some of them are actually hiring telepsychiatry. They see that as the answer. Others, we still don't know what their game plan is. It's early on, and this is 2 Fridays ago.
I know.
I'm sorry, this is Friday. Tomorrow's Friday. Yeah, it's not even been a week since this came out, so we're trying to get y'all, as close as we could, the biggest heads up in time. So we have 2 ways of doing that. We have crisis collaboratives that all the hospitals are part of, and they're in each of the counties and regions. And then we have individual meetings with hospitals, and so we are making those rounds. Now, what we did do is we also distributed this information to the hospitals so they would have the written information. And then we have, of the mobile crisis providers, we met with them today, Paul, and they of course got all our information about this last Friday. And for those providers, they started a discussion with the hospitals because they're in there every day just about. So they've already had some of those discussions. So it is becoming very much aware of that. And that's why, again, we wanted you to know about it, because it's likely that 1 or 2 hospitals may offer quite a bit of complaints about this. So.
Well, and could this possibly increase walk-in?
Yeah, I mean, one of the things that, obviously we're looking at is hopefully the establishment of what we're calling an unsafe place to present the hubs will alleviate some of this. Now, let's not overplay this, because the whole intent of the hub was to divert some people, but when you break your leg, you still need to go to the emergency room. Again, the analogy I use, if you cut your hand, the hub might be the right place, the urgent care center. Okay? If you break your leg, you're still going to be in the ED. So the hub, as we're conceptualizing it, is analogous to urgent care, and only analogous to urgent care. So will it help? I think so. Will it take care of this problem? No. It will take care of part of it.
And if I could add, the right use of mobile crisis, in Paul's example, is that if mobile crisis came to his house and said, you broke your leg, and we're going to help you get to the hospital. Or you cut your hand, your home, and then you won't have to go to the hospital. So that's the right way.
This is scary.
Well, if you broke, if you broke it down for enterprise, it's pretty easy to understand. If a freight line brought it from point A to point B, his responsibility ended. He doesn't get paid going from B to C, the next line does. With humans, it's a little bit different, but I do agree that if I'm a provider and I take somebody to the emergency room, my responsibility ends. And they got 10 people to look after him where I'm just one, and that's probably the reason to take it there. I can't handle it, you know, it's probably a good move. It does require some discussion, but I see the point.
Okay. Thank you, David. Next we'll have the Human Rights Committee fiscal year 13-14 annual report, Mr. Mark Furman, and at the conclusion you will present the consumer rights roster for our consideration, and at the end we'll look for a motion and a second to approve that roster.
Thank you very much. Excuse me, I appreciate the opportunity to come to you today and present the annual report for the committee that has historically been called the Consumer Rights Committee, and hopefully in the future will now be called the Human Rights Committee, as you see in one of our strategic goals. I'm from the great county of Surrey, and it's, as David Swan knows, it's a enjoyable and relaxing but very long ride down here.
And we'll follow you back up.
You followed me back up tonight. We should have gotten together.
He must not drive 77.
But it does give me time to reflect. And as I was coming down here today, I realized that, first of all, I'm very fortunate in that I've been able to serve on the Human Rights Committee since its inception with partners back in July of 2012. So I've been with the committee for its entire duration under the partners banner. And I must say that in the first year, I think we were kind of getting our feet wet, learning what we were supposed to be doing. We had quite a bit of turnover in our membership from the county. Probably only 2 or 3 of us have been there since the beginning. You and I and maybe 1 or 2 others have been there since the beginning. And I felt good, though, because in our second year, I do believe that we have been able to focus on the essential functions of the committee. And I won't go through the report, you have it here, but basically what we do every meeting is review the incident reports for level 1, 2, and 3 with the help of partner staff, and look at individual reports, individual events that have occurred, as well as trends. And that's really what we're there to do as non-partners, external members of the community, to look at that. And all the members of the community have, obviously, an interest in some aspect of either mental health, substance abuse, or IDD. The other thing that we do is we review all the grievance reports. And what has become an offshoot of that, what I believe is very important, is that members of the Human Rights Committee have become panelists on those actual appeals. And that, to me, I've been on several of them myself, and I think that adds the element of having committed, somewhat external individuals being part of the grievance appeal hearings and being able to make certain that the individuals and consumers are not so much adequately being represented, but making sure that their points are coming across to the entire committee. So those 2 things, reviewing the incident reports, handling grievances. I think what has made the second year now considerably better has been the stability of the membership. Even though we only have 11 members, the 11 members have been very solid. We do need some more. But the 11 members are very solid, very committed, come from a variety of backgrounds, points of interest. So we get in different point of views. And we have also had considerable amount of training, both from external training, we had a diversity training, we've had some other trainings, but also within every meeting, we have had kind of an internal training to make sure that those of us who are not mental health professionals understand better the entire appeal process, the grievance process, reports, how we handle that. I must say, I think Dr. Clark has been very helpful to that. He has come to several meetings and given us some guidance, as well as other members. Some providers came one meeting and really helped us out. And I think the core that we have right now with the committee is working very effectively. Certainly, in all fairness, much more effectively than it was during the first year. And I think that we are really adding, quite a bit to the of what can be provided within a human rights committee. The three goals that we have for this year. First one, hopefully, you guys can take care of tonight, is formally changing our name from the Consumer Rights Committee to the Human Rights Committee. Secondly, I think we as a committee have reached the point where we feel comfortable about handling our own internal duties every meeting. We want to start reaching out. We want to start doing a little bit more. I mean, it doesn't do us any good here to sit in this room every 2 months and go over incident reports and level 3 reports and then not do anything about it within the community. So beginning with this coming meeting in October, we will be discussing at length ways in which the committee can spearhead some community interaction using either the provider council, DSS, partner staff. We want to do a little bit more. And I think that the committee as a whole is very much behind that. And the reason everybody is sitting there at the meeting every 2 months and driving from Gastonia or Statesville, or in my case from northern Mount Airy, I practically live in Virginia, is because we want that committee to be able to not only take care of its delegated responsibilities, but to be able to do a little bit more for mental health and substance abuse and IDD within the community. Now, the third thing that I'm here to ask you for is, please, we have 11 solid members right now, but we need some more. And we do have some underrepresented areas. We have not had an active Yadkin County member. We have not had, I've been the one from Surrey, which is fine, and I hope with the blessing of the group to continue on. But we do need some more from just about every county in the catchment area. We could use 4 or 5 or 6 new members. So please, kind of be on the lookout. I can't even begin to imagine, if you put all the Rolodexes or electronic Rolodexes of this room together, how many people that you might come up with that might be interested of coming to 6 meetings a year in this room and trying to do some good for the people who are trying to navigate the system. And I'd be happy to, I'm sorry? We meet right in this room? Yep, right in this room. And I'd be happy to take any questions or concerns and try to answer.
So we look for a motion to formally change the name of the Consumer Rights roster to the Human Rights Committee roster. A motion to change to the Human Rights Committee to the Human Rights Committee, and also to approve the new Human Rights Committee roster as presented by Mr. Furman, which you should have in front of you at today's meeting. Right here. So moved. Second. Any discussions? All those in favor, signify by saying aye. Aye. Any opposed? Thank you. Thank you, Mr. Furman. Thank you very much.
The Human Rights Committee.
Page 11.
The next meeting, is there anything else to discuss? This is close. If I were down there. Good try, Bill. Bill would have been out the door. These policies were included in the agenda package for review. We asked for a motion for all of them at the same time in a second and proceed to any discussion. So looking for a motion to approve all of them, for a second, and then we'll have a discussion.
They're just going to policy, they're not going to talk about them. Done.
Any discussion?
These are the important
Any
things,
discussion?
those last two
All those in
items.
favor, signify by saying aye. Aye. Any opposed? Next meeting will be October 6th. Yes, sir.
Maybe out of order, I'd like to introduce a couple quick motions.
Sure.
That we post a board agenda and our agendas and packets on our website, and also offer an email subscription service to distribute these materials to people who'd like to sign up to receive them.
Second part of that.
Oh, sorry. So, offer a email subscription service if you're interested in signing up to receive updates of board packets and materials, agendas. Automatically, just shoot them out by email.
I wonder if we could just direct staff to develop something for presentation next time as part of our agenda for next time.
Yeah, it might be out of order, but maybe we would table that one.
Can we do that?
All we have to do is provide a link on your website, for God's sake.
To our agenda for the next time, and that'll give staff a month to develop the solution, so perhaps we'll have a solution.
Look at the other LME MCO websites. Jesus.
That's good.
Something simple to fix, and they're that stupid they can't fix it.
I'm telling you, the one in the room with the diagnosis.
Next meeting. October 6th, here. Everybody will stay around, we're getting our photos taken, where will that be?
We will be meeting in the lobby.
Anybody has any printing or including or whatever to do that?
It's about 5.